some nice overlap. You know, it reinforces some of the same points you've been hearing with respect to lifestyle. The nice thing about lifestyle changes, diet, exercise, you address the hyperlipidemia at the same time as the hypertension and diabetes, and that's a really wonderful aspect of that. But I'll also talk about specific drug therapies, when also to think about referring to specialized lipid clinics. Am I okay standing here, Dr. Cooper, in terms of the video?
Oh, you're great. Yeah.
Okay. Okay. So let's see if this advances. Okay. So a little bit more about myself. So I did my fellowship training here in cardiology and specifically focused on preventive cardiology, and thus part of the Ciccarone Center for the Prevention of Heart Disease, led by Roger Blumenthal and Wendy Post. And also, during my fellowship, was here in the School of Public Health doing master's training. I got an MHS degree and collaborate with folks from the Welch Center, so I'm part of the associate faculty with the Welch Center. Co-director of the Advanced Lipid Disorders Clinic. And I specifically in my research have an interest in mobile and digital technologies, how we can use these to better implement what we know in clinical practice. It's amazing. We know so much about evidence, for example, for statin therapies, yet even patients who've had a heart attack, oftentimes after a year, many patients are not even taking these evidence-based therapies. So part of my interest is how do we use technology to remind people, keep them interested, educate people through technology. And now so many people have smartphones. Even I see, patients in the hospital who are homeless who have an Android phone. It's amazing. But yet we might not have to be that fancy about it. It's just using them for simple things, get to your appointments, get linked with transportation. So that's another interest I have, and I'm actually really excited about what you're all doing. There might be potential for, synergy collaboration. Likes to play sports and travel and long walks on the beach. So objectives for this session, just to state these, to learn and define and describe what hyperlipidemia is to our patients, learn risk factors and consequences of uncontrolled hyperlipidemia, and then learning strategies to support our patients' adherence to lifestyle and other guideline recommended anti-hyperlipidemia therapies. So just starting with some self-reflection as a group, thinking about personal experiences with hyperlipidemia, and I'll just sort of go through these and maybe think about your own personal experience here. I don't know if anyone is going to feel comfortable sharing or not, but just reflect yourselves, and certainly if you're interested in sharing with the group, let me know. And also feel free to interrupt me along the way. We can do questions and discussion along the way to keep everyone awake. So do you or your family members or friends have high cholesterol? And I'm sure the answer's got to be yes to that. If you have high cholesterol, how do you manage it? If your family and or friends have high cholesterol, what, if anything, did you do to support them? Did you discuss, the changes that they might be making in their lifestyle or concerns that they might have about the drugs? And then what strategies have you used in the past to help support your patients? I know some of your nurses have clinical experience here with these patients. What have you done to help your patients with their high cholesterol? This is such a common thing that we see. I don't know if anyone, as you reflect on your past experiences, does anyone want to share with the group, have any interesting stories or experiences? And we can also come back to it later as well.
I know for me personally, I was diagnosed with high cholesterol, but mine was because of the types of stuff I had been eating a lot of, like carry-out food, a lot of Chinese food, almost every other night. And so my doctor was like, listen, we can put you on the medication. I was like, no, I know where my cholesterol comes from. I'm just gonna change the types of stuff that I'm eating or how much of it I eat. And so now my cholesterol is fine. as far as strategies about patients, so right now I'm like doing an interim position at Total Healthcare where I'm doing phone triaging right now for the health system, and a lot of calls I get is about lab values. So if someone has an abnormal lab value, they get a letter mailed to their home telling them to call us about their labs to make an appointment. And so a few of the calls have been about cholesterol. So the HDL is up, the LDL is up, the total cholesterol is up. And I just tell the patients, like, this is what you have going on. I'm gonna make your appointment, but by the way, what you eating? Like, tell me what kinds of stuff that you're eating, because if you're eating like a fried chicken every night, that's gonna tear your cholesterol up. And most of the patients are like, you're right, I have been eating a lot of nasty foods. Let me try to work on that. So sometimes for me, it seems like what we eat culturally that sort of drives the cholesterol.
Oh yeah, absolutely. We live in a special culture for sure, and the prior probability that before we even ask, whether that person is eating foods that are contributing to this hyperlipidemia, it's very, very high probability. As part of our culture, the average LDL, bad cholesterol in our society is around 120. And just by comparison, in cultures where they don't have access to easy, fried foods, processed foods, all this stuff where they're more hunter-gatherer culture, there it looks like the typical LDL cholesterol will probably be somewhere around 50. So, 120 versus 50, almost 2 to 3 times higher in our culture. It's clearly related to the foods we eat. I've seen patients in our clinic who went on like a almost exclusively bacon diet, and their cholesterol does skyrocket. But yet there's also people who the cholesterol will be a mix of the genes they were born with and what they're eating. Or there'll be patients who it's really all from the genes. So, and we'll talk more about that, thinking about that, differentiating that. There's some people who are born very lucky with cholesterol genes where they could eat a ton of fatty food, yet their cholesterol is going to remain very, very, very low throughout their life. So it's an interaction between the genes and environment. But I very much can relate to what you're describing. Any other experiences anyone wanted to share? Okay, let me.
I can share.
Yeah.
So I just recently got diagnosed with high cholesterol myself, much to my chagrin, because I think I actually have a pretty healthy diet. But I do have a family history of heart disease. So, and then also, I also know that with age, these kinds of things happen.
Right.
So one of the things that that I've been told, obviously, and that I know by virtue of being a physician is, how to reduce some of the dietary, fats that contribute to high cholesterol. So I've been trying to work on that. Of course, with my job, it can be challenging to do all the lifestyle changes. So I can definitely relate to my patients and, how hard it is to work in like regular physical activity and maintaining weight. But I know things like switching out from like whole milk, for example, or 2% down to like skim is like one strategy, and sort of cutting back on things like cheeses and butter, which everybody loves butter. And again, focusing on eating like lower fat meat and things like that can help. But I think this is a challenging issue, especially for people who are genetically predisposed to having higher cholesterol.
Yeah, absolutely. Thank you. You brought up a number of good points about family history, which I'm going to try to touch on a bit later. And it might relate to something called familial hypercholesterolemia, but maybe it's related to other issues. Age, definitely the cholesterol, the bad cholesterol, as we go through our 20s, 30s, 40s, 50s, it's going up, up, up. And then around 50s, 60s, it then does plateau or even start coming down. The but the risk is related to the cumulative exposure, and I'll come into this. The years. Think about with smoking. We talk about pack years for someone. Think about their LDL years, their bad cholesterol years of exposure, and that's important. So if what the cholesterol was earlier in life, that can help guide you in terms of how much of it is genes versus change in age and lifestyle. A lot of good points there we'll come back to. But lifestyle change is so hard, and the way I talk to patients generally is trying to just we're not trying to achieve perfection here, but make improvements. So just some very basics here. Cholesterol is carried in the blood along with triglycerides in lipoproteins, packaged into lipoproteins. So think about this circular molecule. On the outside is phospholipids, and because the blood fats are not, they're hydrophobic. They don't like interacting with the water. So we need something to package them in that likes the water hydrophilic. So those that is the phospholipids, which then interact with that package the cholesterol and triglycerides. So then each particle will have a certain amount of cholesterol and triglycerides. So that's how the blood fats travel. When blood cholesterol stays elevated over time, it can deposit in the arteries. And that's what I was just talking about with this cumulative exposure, that it's not like you have high cholesterol for a week and now you're getting bad atherosclerosis, heart disease. This is something that happens over years, and it's that cumulative exposure over years. So we say hyperlipidemia as the medical term for high blood cholesterol, but you might also hear hypercholesterolemia. You might also hear dyslipidemia. There's all sorts of terms that basically mean the same thing, and this has serious medical consequences in terms of heart disease, stroke, and these are atherosclerosis-related disorders, but then also pancreatitis in patients who have severe triglyceride elevations, especially over 500 milligrams per deciliter. These are patients who are at high risk for pancreatitis, which is hospitalized condition, life-threatening condition. Peripheral vascular disease and other things as well, like erectile dysfunction these patients are at risk for. Hyperlipidemia, the key thing, and this goes along with hypertension, with diabetes, often they're asymptomatic. The key thing is that there's risk happening over years and years and years, but they may not feel anything, and then when we treat it, they may not feel any differently. And that's that's part of what makes it so hard to treat, that the drugs don't make you feel better until they prevent that day when you come in the hospital with the heart attack or the stroke or something, or a cardiovascular event. So you can have it for years without knowing it. Helping patients know their lipid numbers is key, and you mentioned talking to the patients on the phone about their numbers, and that's what guides us, these numbers, because we can't feel it. We go by the objective evidence that we have, which in a way makes this easier because we do have an objective thing that we're targeting with treatment. So the standard lipid profile that's done most commonly to assess lipids, but I'll mention some other approaches to assessing lipids, includes a direct measurement of total cholesterol, of direct measurement of triglycerides. So these are the two things that are packaged up in those lipoproteins. And then HDL cholesterol, which is the higher density form of cholesterol, so-called good cholesterol, although that term is probably going by the wayside because it's clear that that's too simplistic of thinking. So the LDL cholesterol, the bad cholesterol, is then calculated from the rest of these parameters. So typically it's said that a value less than 200 is really optimal. And then for HDL cholesterol, it's classically said that less than 40 in a man or less than 50 in a woman is abnormally low. So women tend to have higher HDL cholesterol levels than men related to their hormones. So I mentioned, that the cholesterol disorders can lead to cardiovascular events, other things, but there are also, they can lead to physical exam manifestations. It's not a straight line here in the Achilles tendon. There's some outpouching there from thickening from the lipid deposits in the Achilles tendon. And if you feel that, it's not going to, at the bottom of the Achilles tendon, it's not going to be a nice thin tendon. It's a thick tendon that you can feel there. Again, from high LDL levels from familial hypercholesterolemia. So this is something that the patient is born with, and it accelerates cardiovascular disease, especially coronary heart disease. So classically, half of untreated men and about a third of untreated women will have a coronary event, a heart attack, before age 50 and 60, respectively. And in terms of how common this is, the form of this called homozygous FH, where you have these cholesterol levels, is truly rare. Probably 1 in 250,000 people have this, where you have two genes, one from mom, one from dad, that lead to very high LDL levels. The key point is that the heterozygous form, where you get one gene, either from mom or dad, is actually more common than has classically been thought. So in the US and European populations, it looks like it's present in about 1 in 200, 1 in 250 people with these kind of total cholesterol levels being characteristic. Or think about an LDL level of 190 or more as triggering your thoughts about this. So this equates to a lot of people, probably about 1 million or over 1 million in the US. That's a lot of people, or over 20 million people worldwide. And there hasn't been a lot of recognition of this, and it's estimated that only about 10% of these folks in the US have actually been diagnosed with familial hypercholesterolemia. So this is an area where I think you all have a great opportunity to make an impact if you're keeping your eyes open for patients with these very high LDL levels. You look in their eyes, you see those knots on their hands or their Achilles tendons. You're going to pick up people with this because it's 1 in 200 or so people. And these are the types of people you'd want to then refer to a specialized lipid center. In terms of how we classify hyperlipidemia, one way to classify it is just based on those levels that I showed you, total cholesterol above 200, LDL above 130. That's one simple way to classify it. The classical way that's been adopted by the World Health Organization, although I will admit is not used by most practitioners, even though we're taught this in school and it's adopted by the WHO. Not a lot of people are really using this in clinical practice, and part of the reason is you can't make these determinations just based on a standard lipid profile. You'd need another measure called apolipoprotein B, which is a measure of how many bad particles there are in the blood, and there's a smartphone app called the ApoB app where you then can plug in the numbers and come up with these types. Maybe in the future we'll move to that kind of model. We're not there yet, but I wanted to bring up that this is the classic classification. And one of these in particular, type 4, where you have elevated VLDL, very low density lipoproteins, is probably much more common than it used to be because it can be very much aggravated by obesity and diabetes. So those types of patients tend to get these high VLDL levels, and these tend to have more triglycerides relative to the cholesterol content. So these patients have higher triglycerides often have this in excess and type 4. So the one point is that these are not necessarily going to be rare disorders, but in clinical practice we haven't yet operationalized how to actually pick apart these people outside of specialized lipid centers. But that FH that I was talking about falls into type 2A, where you have elevated LDL cholesterol. So this gets into the idea of genes versus lifestyle, and often it's going to be a mix of the two. And when we think about risk factors for developing hyperlipidemia, there's the family history of high cholesterol. And when it comes to things like familial hypercholesterol intensity, moderate intensity, there's also low intensity. High intensity is pretty simple in that there's only two statins that meet this criteria. It's atorvastatin, also known as Lipitor, or rosuvastatin, also known as Crestor. So those are the two at doses of 40 to 80 and 20 to 40 for Crestor that are considered high intensity statin therapy. And then you see there's a long list of options for moderate intensity statins, and these include the lower doses of atorva, rosuva, but also include these doses of Simva, Prava, Lova, Fluva, and pitavastatin. So lots of options there for moderate intensity statin. The definition of high intensity is on average lowering LDL by 50% or more, and then moderate intensity is somewhere in the 30 to 50% range. Any questions about those, or anyone want to share personal experiences with any of those statins? So this is then a continuation of that flow chart, and we talked about the first three groups: those who have ASCVD, those who have LDL 190 or more, those who have diabetes. The fourth group is primary prevention without those disorders, and now we do the 10-year risk estimation. So it may be in the chart, or I may go online. I might go on my smartphone and go into the risk estimator and calculate this 10-year risk. And if it comes out as 7.5% or more, now there's a recommendation for consideration of a moderate or high intensity statin. And it's not that it leads to, this is the key point, that it leads to automatic prescription, but it leads to a discussion. And we wrote an entire paper about this, myself, Roger Blumenthal, along with Neil Stone, who is the chair of these ACCHA guidelines. We wrote a whole paper talking about what goes into this discussion, this patient-clinician discussion. To summarize, it starts with assessing, talking to the patient about this risk. You know, what are the factors, the age, the hypertension, the lipids that are contributing to that risk. Thinking about how convinced are we that that's a good representation of their risk. And if we're not 100% convinced, we can consider other factors that that reinforce the risk. So if their LDL levels 160 or more, if they have that family history, we commonly in our center do what's called a coronary calcium score, and I'm sure you'll see some patients who have these calcium scores. They're actually quite cheap to obtain and fairly popular, especially in the Baltimore region. That can help reinforce whether that person's at high cardiovascular risk. That's a measure of calcium in the coronary arteries, which is a marker of plaque. Looking at potential for adverse effects, you know, is this someone who's older on a lot of different drugs that might interact with the statin, or is it a younger person who doesn't have much potential for these drug-drug interactions? Definitely addressing lifestyle, other risk factors. You know, when we're thinking about a statin, but their blood pressure is not controlled and they're still smoking, we need to be addressing these things, not just focusing on cholesterol. And also, this is, you know, one of the key points as we framed this paper that we wrote in terms of what does the patient think? What are we, what is their preference? How willing are they to take another medication? You know, getting into a back and forth shared decision-making process if they're willing to engage in that type of back and forth dialogue. What are their concerns about the statin? Making sure that these things are addressed before the prescription is given, that there's actually buy-in to that prescription. So part of this is discussing what the patient's done in the past or doing now to try to manage the high cholesterol. Have any of their family members had premature heart disease, so heart attack before age 65, or in a female relative, or before 55 in a male relative? I find that patients who've had those family histories often are more motivated. You see patients whose mother had a bypass surgery at an early age from heart disease, wants to do everything possible to avoid that same fate. And so this family history can be very important to consider and motivating. Has your doctor prescribed medications previously? Tell me about what you know about lowering cholesterol with your diet, and how have prior treatments worked? How are they working now? Certainly in a context of our clinic, we see a lot of patients, because of referral patterns, who've had prior trouble with trying a statin. And so that's part of the issue, is dealing with those prior treatments. Does anybody have anything they want to share about these issues or these questions from your personal experiences or practices?
I'm a community health worker, but I have patients who talk about leg cramps when they start with the statins, and or some of them are concerned about possible leg cramps. So they're that's one thing that seems to come up, and then some of them are like, well, why can't I just do fish oil, and why do I have to take a statin?
Mm-hmm. Okay, both really good points. Yeah, I see patients all the time who are having leg cramps, and it's a big debate. It's thought that about 20% or so of patients in practice are going to have statin intolerance or those types of leg cramps. So very, very common. Part of the scientific debate is that in clinical trials, the patients who take placebos tend to have the same amount of leg cramps as those who take statins. And so there's this discordance between what's seen in the clinical trials and then what's seen in practice. And it's thought that at least part of this is there's something called the Nocebo Effect, where patients are because they've been told to expect it by their doctor, or they've been told to expect it by the newspaper or by a friend, that they anticipate the leg cramps and then they get them, and it's attributed to the statin. Or they may have actually already had some leg cramps because they're older, or joint problems, and now all of a sudden there's more attention to that and it's attributed to the statins. Part of it is certainly that. Part of it is real muscle cramps that someone's having related to the statins. We know there's muscle effects, and we do believe that some portion of patients will have that, although it's probably much, much less than is commonly perceived. It's a tricky thing. Honestly, I don't have a great answer for it, because when someone has it, we don't have a way to really know whether it's from the statin or not. But we can have them go off the statin, go back on, try something else. We can measure their muscle test, the CK level in the blood, to see if there's any actual objective evidence of muscle breakdowns or just the cramps. One thing to think about is that sometimes these are patients, at least the guidelines recommend that it might be that their vitamin D levels are low, and so if they just go out and get a little bit more walking outside with a little more sunlight, or they get vitamin D supplementation, that possibly could help. The fish oil thing's really interesting, and there's a lot of folks are taking that. It's available over the counter. It will not lower LDL cholesterol, so it actually may raise LDL cholesterol a little. It's a good triglyceride lowering therapy, and we would use it for that purpose, but not to lower LDL. The concern that we have in our lipid clinic about the over-the-counter fish oils is that there's been studies that show that actually they have a lot of contamination in them, a lot of saturated fats actually in them, so they may not be so good to take. So we stick exclusively to the prescription ones, which we know are purified and have the good oils that can help lower triglycerides. So we discourage use of over-the-counter. It's just a waste of money. It may actually have stuff that you don't want coming through.
Thank you.
So diet, physical activity, sometimes I find this a little boring to talk about, because I feel like people know this stuff already, and I'm sure this probably reinforces things that were said before, but from the perspective of myself, our preventive cardiology group, our lipid clinic, and the guidelines, we tend to emphasize a Mediterranean style diet because this has been studied in randomized clinical trials, or similar to a DASH-like diet, and I'm sure that fits with what is being recommended by others in part of this study. So emphasizing vegetables, fruits, whole grains, low-fat dairy, poultry, fish, legumes, non-tropical vegetable oils and nuts, avoiding sweets, sugar-sweetened beverages, Pepsis, Coca-Colas, and limiting red meat intake. Reducing saturated fats, which drive up the cholesterol levels, and trans fat intake, 5 to 6% of calories, although I've never been a big fan of these percentages because it's hard to really track or recommend that. So more focusing on what is being consumed, these whole foods, these fresh fruits and vegetables. In terms of exercise, the bare minimum is 3 to 4 sessions a week of moderate to vigorous aerobic activity, so brisk walking for 10 minutes or more, ideally for 30 or 40-minute sessions, at least 3 to 4 times a week as a minimum, but more would be better. So thinking about some self-management goals, in terms of weight loss, we tend to recommend having an achievable goal within a defined period of time. So here's an example of 10 pounds in the next 3 months. Increasing physical activity. So it might be that we are so far below that recommended amount that we're not going to go right there, but at least we can start introducing a brisk walk 20 minutes during lunch. And this is part of maybe the motivational interviewing strategy. We sort of get our patients to start thinking, brainstorming what is the point in their day when they could incorporate a brisk walk. And maybe it even could be, if they have meetings, that they could turn one of those meetings into a walking meeting. Or if they're on a conference call, they can walk while they're on a call on their mobile phone or things like that, figuring out how to incorporate it into the day. Improving the diet, eating 2 more fruits and 3 vegetables every day for the next 2 weeks. Tracking cholesterol. So if they're starting on statin medication, following that up 6 weeks or so later. There was some confusion after the last guidelines that you sort of just start the statin and then it doesn't need to be followed up anymore because there's no more targets. But that really the guidelines very strongly recommended following up. I'll get more into that. And then taking it every day, getting it on a routine schedule. Some patients benefit from using pill boxes to keep organized and take them, the statin at the time that they need, but that's really critical to get in that habit. So I said I'd talk more about the follow-up. So this is what the ACC/AHA guidelines recommended in terms of following up if your patient is starting on a new drug on a statin. So they want us to assess for that expected response. So we talked about the high intensity, moderate intensity, moderate being a 30 to 50% reduction in the LDL, high intensity being 50% or more. So they want us to see from the baseline LDL to now the follow-up 6 weeks or so later, has it gone down, how much we would expect it. And if it did, then that's great. And we were talking about our patients at that time about the fact that the benefits of this are not from taking this for 6 weeks, but from taking this for years and years and years. So we're talking about now we need to make this a habit and keep on this over time. And this is a big, big problem where patients, don't really realize the duration of therapy. It's almost like, okay, I get treated for 6 months and okay, I'm good. This is something this is a lifelong issue. Treatment, the clinical trials have gone 3-5 years, but we think the benefits of this are beyond that. That's where the benefit really comes from taking this for a long period of time. So we're emphasizing that. We're continuing not to forget about the lifestyle and reinforcing lifestyle. Now, if they don't have that reduction, that percentage reduction we're thinking, and then the guidelines did also, they didn't have targets. They did say if the LDL cholesterol is still not less than 100, then we should be thinking about what else can we do. And so we're probing the patient, are you having trouble with the statin in terms of any side effects? Are you having trouble affording it, taking it? Making sure that they're actually taking it, and it's not a simple reason why it hasn't come down as much as we would hope. And then if they are having problems, that is definitely a time you then probably want to refer them to a specialized lipid center to assess those problems that they're having with statin. So we're happy to see patients in our clinic. And actually, speaking of that, I'll leave some cards here. It has my email. You can email me. The number on that card goes to my assistant, and she can schedule patients in our clinic. So those patients who have trouble with the statin, that would be a good time to refer them in. So we're reinforcing adherence. And then if all looks well and good, we're doing what we want to be doing. We're on track with lifestyle, we're on track with statin, but yet the lipid response is not what we want. And this will be the case for those patients with familial hypercholesterolemia who I mentioned. A statin is almost always not going to be enough to get their response in the percentage or the actual on-treatment level to where we want it. This is where we're thinking about non-statin therapies, and those are going to include Zetia and now PCSK9 inhibitors, these injectable medications that how many people have heard about PCSK9 inhibitors? Injectable cholesterol therapies. You'll be hearing more about them. It's, on the news. There's been some big clinical trials. They're very expensive, but those are the things we'd be thinking about in terms of changing the treatment plan. And that would be another reason to refer them to a specialized lipid center. So increasing the dose. Now, if they're already on the high intensity statin, then there's no room to increase the dose of that any further. If they're on the moderate intensity, you can increase it, although don't expect amazing and additional response. It might be that you got a 40% and now you're going to get a 50% response, only another 10%. With each doubling of the statin, we generally say there's a rule of 6, so you get another 6% lowering. So it's not a big response. Adding another medicine, Zetia is a fairly gentle lipid medication. You get a 20% reduction, although that may be equivalent to 3 doublings of the statin. So in that sense, it's actually quite significant. One statin, we may have, and the nice thing is we have a bunch of different choices. We may try a different one. In particular, lower doses of the rosuvastatin can be very well tolerated in patients who've had prior statin intolerance and still produce a good 30% or more effect. Stopping one of your medicines. So you mentioned earlier the muscle cramps. That would be a good time to stop the medicine. Again, the benefits of these are over years and years and years. There's not a big deal of just stopping. So let's stop for 2 weeks, see if those muscle cramps go away, and then maybe we can re-challenge. At that point, they could be referred into a lipid center. Talking with your doctor about any concerns that you have about the treatment. We get a lot of, at least in our clinic, patients who've read on the internet, seen Dr. Oz, they've read the Great Cholesterol Myth book. This is very common. These are bestsellers. So there's a lot of misperceptions. And these are books that are written by folks who are pushing vitamins, and often they're selling their own vitamins. There's a lot of ulterior agendas there by the folks that are pushing these things. They're not the folks who are publishing legitimate scientific studies and all that, but there's a lot of misinformation. And as a patient, it's nice to hear, oh no, actually don't worry about that, you're fine, just take CoQ10 and you'll be okay, or, and there's actually good messages in the books, about diet and things to change, and they're absolutely right. As a culture, we really need to change our diet, but there's a lot of misinformation about these sort of anti-statin movements. And in other countries like Australia, there's been broadcasts national broadcast anti-statin stuff. And then they've actually documented a massive increase in heart attacks after those broadcasts because people are going off their therapies. So that's something to pay attention to, and patients are going to bring up these concerns a lot. A lot of patients are justifiably worried about diabetes, which is a definitely a documented effect of statins, but it's a very modest effect happening in people who already are on their way to diabetes, and the benefits still outweigh the risks in those patients. So as we've gone along, I've made a number of comments about referrals, but to summarize in terms of referring to a preventive cardiologist, lipid center like ours, patients who you notice have strong family histories, have very high LDLs, have familial hypercholesterolemia, patient where you actually see those xanthomas on their hands that I showed you, or the rings in their eyes, patients who are having trouble with the statin or their lipid medications, patients who are just very high risk, have heart disease plus diabetes. These are the high risk populations. These would be very reasonable to refer over. In terms of, maybe you all can help me out in terms of when would we refer to a community health worker. Does anyone have any perspective on that?
I would say maybe access to community resources or
Yeah.
just some other resources. Maybe you want to find out where's the closest rec that's free or something like that you can go and use their gym equipment.
Oh, yeah. Okay, that's great. That's great. Any other?
Well, no, I agree. It's with the community resources. A lot of times expenses
Uh-huh.
are a big issue
Yeah.
with patients.
Okay.
Is how they're going to pay for their medications.
Definitely.
Financial assistance with that.
Definitely.
But I noticed you put the FH Foundation down as a contact with
Yep.
community resources. Do they assist with medication?
They don't directly have a program that I know that'll help pay for medicines, but they have been helpful to some patients who've been trying to get on these new cholesterol medications in connecting them with programs that do assist. So there is a Safety Net Foundation that I've had a patient who was connected with the Safety Net Foundation and got support to pay for their PCSK9 inhibitor through the Safety Net Foundation. They have like a Facebook group and a really strong community of patients who've been through a lot of the hurdles of insurance approvals. So they have quite a lot of experience who can give patients some guidance. Even though they may not be able to pay for the drug, they may be able to provide support and guidance. It's a patient-started foundation. The patient, Catherine Willimon, who started the foundation, has familial hypercholesterolemia, and then she's been very successful building out this foundation. They have a national registry study that we're participating in. So I think they would serve as a great resource to someone who needs guidance through this complex maze of healthcare and approvals that we now are in for those things. In terms of cost for statins, the beauty there is that they've been around enough that we have a number of $4 a month options, $10, for 3 months kind of options. So usually we can find a reasonable option there. Now the statins are pretty much all generic. The Lipitor and the Crestor recently, the Atorva, Rasuva were more recently generic, so they may not always be as low cost as some of the others that have been around for a while, but we have a lot of good options. Even Zetia is now generic, Ezetimibe is now generic.
Thank you.
Yeah, so the cost there can be more manageable. Another health professional, pharmacists are super helpful colleagues in this. We've partnered very closely with the pharmacists at Hopkins to manage some of the complexities of these insurance approvals for the new PCSK9 inhibitors. But I think pharmacists can be a great resource to helping reinforce, medication adherence and helping assess side effects. All the pharmacists really, I try to partner with them anytime I can. We have a dedicated dietitian with our lipid clinic, who really is often one of the central interventions that we do for our patients, is to start working with that dietitian. So I certainly encourage as much involvement as dietitians in managing these patients as possible. Social workers, absolutely critical, obviously, in terms of dealing with some of these fundamental cost issues, transportation issues, other things. Psychologists, I have to be very careful with someone with statin intolerance, inferring that they need to see a psychologist. Sometimes they are the, to be very frank, the most difficult patients to deal with who have had statin intolerance. But I am very clear with them that I believe what they're feeling is absolutely real. That the muscle cramps they're absolutely feeling, even if I don't know for sure that it's from the drug. I absolutely believe it's a real thing. But sometimes there are underlying depressive anxiety issues that should be addressed, that absolutely should be addressed. So addressing social determinants of health can affect patients' ability to manage their blood cholesterol. I think this is completely underappreciated, how important these social determinants of health are in managing our patients. We spend so much time debating the exact threshold when we might start a statin, and put a lot of time and effort into thinking about these things. But then, even then, I think we very vastly underperform in managing cholesterol, and this has been shown again and again and again. And there's been very little improvement over decades in terms of controlling cholesterol within population. I think this is a big part of it, that we're not addressing some very fundamental aspects of access to care, our social determinants of health that impact these things. And some of this has already come up in our discussions in terms of economic stability and being able to afford these therapies, and not only afford paying the $4 for the drug, but then the transportation to get back to clinic, the follow-up appointments, whatever co-pays are coming with these things. So these are big issues for sure. And then when we start recommending to our patients to do more exercise, there's fundamental issues there. How well supported are they within their community to actually do that exercise? Do they have access to a safe local park where they can walk around and do these things, and or a gym that they can go to? Education, obviously critical. I know that I say so many things to my patients in clinic, and I spend so much time counseling, and that I don't know how much of it is actually understood. I'm amazed at sometimes when I do follow-up calls with patients, and I realize how ineffective I was at actually conveying the messages, even though I felt like I said it again and again, and I typed it up sometimes. So really, there's a lot of opportunity for clarification of the treatment plan with patients. What do they really hear the clinicians say? Following up on that, it's amazing how much confusion there can be. And like my assistant will call a patient, I'll talk to the patient, and how we're just getting discrepant information from what they're hearing. I think encouraging our patients as much as possible to have family members or friends supporting them in their care, helping reinforce information, hearing what we all are saying in terms of their medical care. A lot of these patients that I'm seeing with heart disease, cholesterol, are older folks, and they probably, in many cases, have some mild cognitive impairment, might even have early dementia, and this influences their ability, on top of the fact that they may not have good health literacy. I've been taught to try to talk it as low level. Even if you have a doctor or a health provider as your patient, they probably have low health literacy, is what I've been told. So this is a major thing. Food. Early when I was in my college years, I did a project where just about the discrepancy in terms of cost of healthy foods. They're more expensive. The energy dense foods are cheaper. So to eat the unhealthy stuff, we're financially incentivized towards that stuff. So there's so much about our system that's pushing patients away from getting good cholesterol control. just the way it's built in. So we're almost fighting an uphill battle. Social integration, support systems, community engagement. I think, I mentioned the Facebook group or things like for the FH Foundation. These can be good tools there. Several strategies to connect patients, Maryland mobility, if it's trouble with getting to appointments. I'm sure you all, already are well aware of American Heart Association initiatives. Does anyone have experience with the YMCA, getting patients, any programs there for physical activity or anything? I don't know a ton about the YMCA, but they seem we had one phone call with them recently, and they seem very interested in seeing these patients to help with exercise, with heart disease, and risk factors for heart disease. And I mentioned the FH Foundation. Any, I'm sure there's others that I'm missing here as well. Any other thoughts from the group about other community resources that could be useful to patients with hypercholesterolemia and cardiovascular risk?
Senior centers, so that they become familiar with
Senior
where
center.
the local senior center is.
Uh-huh.
Some of the senior centers in different counties actually offer transportation to their center
Oh, wow.
and back. So just becoming familiar with the senior centers for those people who are older,
Uh-huh.
and what resources they might be able to have that are free of charge or low cost to the residents.
The AHA had like a healthy food kitchen, although did that close or is it still up and running?
It's still there.
It's still up and running.
Yeah, not too far from here.
It's
Have
on-
you guys heard of the kitchen, the community kitchen at American Heart?
It's on, which street was it on? It was Central or,
Yeah,
yeah,
where,
down,
that's colleges.
yeah.
You know, right on the corner of, I think, Central and, Pratt,
Yeah,
yeah.
The healthy
But
college.
basically,
health-
people can go there and they pay, what, is it $5?
$5 for a
And
cooking
they get
class.
a cooking class, and then they take the food home for it. It's like a full meal for their family. They really teach them how to prepare like food, like lower calories,
Yeah.
lower sodium, salt content, and they have a lot of recipes. They show
Yeah.
people how to slice vegetables. You know, it sounds like basic, but there are a lot of people who just like
Yeah.
never learn how to cook because they just got used to just buying fast foods or packaged foods and things like that. So it's really great.
It's the first one in the country like that, so very innovative. And there's something to be said for like, we can talk about what you should do, but then actually doing it, cooking the type of, it could be very powerful. Supporting patients and maintaining behavior change, establishing trust and rapport with the patient. I think this gets into some of the things we were discussing earlier about, shared decision making, asking what is their preference, how motivated they are based potentially on the family history, identifying patients' barriers to adherence. And certainly that reinforces things we've talked to about fundamental things like cost transportation, identifying patients' self-management goals. And I think that's a time to talk about, the goal is not just we want to lower cholesterol, but goal is I want to avoid bypass surgery like my mother had. I want to avoid ever having a heart attack or a stroke. I want to avoid diabetes. I'm starting on the statin and I don't want to get diabetes, and that's a great time to talk about how important lifestyle is in preventing the progression to diabetes. Employing motivational interviewing, so we're not just saying exercise more, but getting the patient brainstorming about, well, how can they fit more exercise or just more walking, physical activity into their day, again, during maybe the lunch break, turning a meeting into a walking meeting, walking while they're on their cell phone, parking further away, taking the stairs, all these things that may help. So I guess that was it. These were the additional resources I had mentioned. I focused in on the ACC-AHA guidelines, even though there's actually a number of other guidelines in the U.S., like the National Lipid Association guidelines. These are the ones that are most commonly used. And then this is the link to the risk estimator app. So in that fourth group, they don't have CVD, diabetes, or LDL cholesterol 190 or more, that fourth group that you would calculate their 10-year risk to guide decision-making can be done online on a computer or on a smartphone or tablet. Roger Blumenthal and I serve as the co-editors for the American College of Cardiology's dyslipidemia community. So we get a lot of good content there on the latest things happening for cholesterol lipid control. I mentioned the FH Foundation. Here's their website, and then our Chickaroni Center. There's been a lot of articles through our Chickaroni Center that are fairly concise and talk about practical tips related to managing cholesterol, but also, again, this is about managing cholesterol, but it's part of the comprehensive approach to prevention. And to put it, the cholesterol in context, we have an ABCs model to the Chickaroni Center. So the C is for cigarettes, and then for cholesterol, which I'm talking about now. The A is for age, and also thinking about if they're on antiplatelet aspirin therapy. The D for diet, diabetes, which you just heard about, and then E for exercise. So it's, addressing, when we're addressing one of these things too, we want to be thinking comprehensively, because if you can make even if you're not perfect in any of them, if you do a dent in each of these risk factors, you can have a really, really big effect on preventing heart disease. So summary, hyperlipidemia or dyslipidemia is a serious condition that can lead to heart disease, stroke, pancreatitis in the case of high triglycerides, peripheral vascular disease, and other things like erectile dysfunction. The best way to screen for and diagnose hyperlipidemia is simply to do a standard lipid profile, which will give you total HDL cholesterol, triglycerides, and then you'll get the calculated LDL. In addition to healthy lifestyle, statins are first-line drug therapy to lower lipid-related cardiovascular risk in patients with hypercholesterolemia. Non-statin therapy plays a role in selected high-risk patients, like those patients with FH or established cardiovascular disease, when added to a healthy lifestyle and max-tolerated statin. And Zetia, PCSK9 inhibitors are the two that we're thinking about on top of statins. Follow-up lipid monitoring, despite lipid targets per se being taken out of the guidelines, they're really on their way to coming back into the guidelines, but regardless, follow-up lipid monitoring remains very important to assessing adherence, adequacy of therapy, and then to guide further adjustment of their medications.
You were saying every 6 weeks or something?
After starting or adjusting, you would tend to do it after 6 weeks, and that's not like a rigid thing. The most of the effect happens even before 6 weeks, but it could be anywhere. The guidelines say anywhere between 4 and 12 weeks. So between 1 month, 3 months would be fine to do it in that time period. So thank you very much. It's a pleasure to join you. I'm really excited about your Rich Life study, your Rich Life initiative, and I hope to be able to collaborate with you all in the future. Thank you. Any other questions, comments, or do you just want to get to lunch?
With the injectable, how do they inject it?
Oh, yeah.
Where?
Good
Is it going to be
question.
arm, leg, thigh?
All the above, yeah.
It's like-
Arm, abdomen, thighs, subcutaneous,
Okay.
every 2 weeks or once a month, but typically every 2 weeks. And we've actually had good experience in our clinic where patients tolerate it very well. Even folks who weren't, big fans of needles, they were a bit scared, were hesitant, have done just fine with it. I mean, it's only every 2 weeks. It's a small needle, and the only people who have had trouble are people that go too deep. They're really aggressive with their injection and they want to get it so deep and they're like getting blood back. That's not what we need. It just has to go lightly under the skin and it works. So people have done really well with it. It's really, and it takes like 15 seconds and it's done. Yeah.
Covered under Medicare?
It can be. Approvals from insurance are very challenging. There's been studies recently that have shown that approvals are 50% or less, typically much less across the country. We've had 85% approval in our clinic, but that includes having to appeal quite commonly. So it can be approved, but you have to select the right patients, have really good documentation, and you have to be vigilant about appealing when it gets denied.
Thank you.
Yeah. All right, thanks. Thanks very much. I'll leave these cards up here in case you need my email or anything, okay? Thank you.
Thank you. Feel free to grab lunch.